Lovely. That's great. Thank you. I'll just get on. Thanks very much for asking me to talk. Um, I wanted just to run through a few developments in the field of allergy, but also looking particularly at how people who have a clinical role in asthma care of children can help children with food allergies. So I've entitled this Asthma Practitioners, Your Role in the Prevention of Allergy Deaths. How about that? Um, so Um, this is from the National Child Mortality Database. They did a report last year on asthma and allergy deaths, and I'm sure as a community you're all very familiar with this report. So I'm not going to go through it very in great detail, but it has really important points for all of us. Firstly, that the majority of children's deaths from asthma and allergies are preventable. Each death is a heartbreaking tragedy, but preventing another child dying is the responsibility of us all, and that this responsibility sits across our multi-agency services, and that means that our allergy services too, and with our communities and our societies, is everybody's business. This is the key findings, and you can see that right at the bottom here, allergies is one of the factors involved in child deaths due to asthma, and that's something we're just going to highlight and look at in more detail. We know that child deaths due to anaphylaxis, very much like asthma deaths, actually increase according to the child's age, 15 to 17 being the highest age group. And we know from other studies that the age group between 15 and 25 is the highest rate of anaphylaxis and allergy deaths across the life course. And I think part of that is the same that we see for all chronic diseases, in that the outcomes drop off during that transition period. If you think about adolescence in its widest age group, really, that if you've got kidney disease, you've got CF, you've got insulin-dependent diabetes, you're going to have a drop off in your care, in your outcomes during the period, during that transition period, and food allergies is no different. Half of them occurred at home, and half of them outside of the house. Um, this is something that's interesting and a flag, really, that half of them had attended the emergency department in the year before death, and that all of the children with anaphylaxis who died were also known to have asthma. There were 19 children deaths between with anaphylaxis in that 4-year period as well. We might come back to that. We'll see where we are. So the most common food allergies causing deaths were nuts, milk, and eggs. And that the coroners said that public safety, unclear labelling is an issue, which is improving dramatically, actually. And you might have noticed that in restaurants in the last few years, it is now normal practice for the waiter to ask whether you have any food allergies in your party. Doesn't mean that the adolescent is going to tell them that they've got a food allergy, but at least you're getting asked. And that we have standardized allergy plans now. These are the number of children who died of asthma. You can see my cursor when I move it around. So we have food allergy, non-food allergy, and eczema. And there's, like all atopic diseases, then there is overlap between them. So of these asthma deaths, children with allergies and eczema, 36 of them had allergies, 15 also had eczema. 19 had no information about it at all. 27 children had allergies to food items. 22 were allergic to non-food items, including hay fever. And 13 had allergies to both food and non-food items. So this overlap of allergic disease. The most common food allergies recorded in the reviews of child death were nuts, peanuts, and tree nuts like cashew, hazelnut, walnut, cow's milk, egg, and less so seafood. Seafood is the most common adult allergy, but it's actually quite unusual in children to have a seafood allergy in the UK. And of course, the sort of foods you become allergic to vary according to which part of the world you are, because your diet changes. So, um, emergency hospital attendances, half of them had attended in the year prior to death, and that 21% of them also had at least one hospital emergency inpatient admission, so not just an attendance, but an admission. And in 3 or 4 of these cases, asthma was the primary reason for admission. So children with food allergy who have asthma that end up in either in the emergency department or admitted overnight, that is a risk factor for them having a significant anaphylactic reaction to food, and that's something that's potentially preventable. Although other foods were foods like nuts often have a bad reputation, and rightly so, because they have unpredictable reactions. Actually, the the greatest number of fatal anaphylaxis reactions was related to milk. IgE-mediated reactions to milk, 8 of those, compared to 3 for peanuts, 2 for tree nuts, 2 for egg, and a couple for seafood, and a drug reaction as well. Some teenagers are exquisitely sensitive to milk, and I have patients who will get wheezy when they walk into a coffee shop because the milk aerosol produced by the coffee machines. And I have some patients that are so sensitive that they get an itchy mouth when they take a 10 mg tablet of Montelukast because it contains pharmaceutical lactose, and we have to give them 2 5 mg tablets instead, which don't have lactose in them. These are the patients, if they've got asthma as well, these are the patients that are going to come a cropper. So milk allergy is a major risk factor. The problem is it's often hidden in foods and difficult to avoid. The risks are children who are unable to tolerate milk in well-baked products. So there's a stepwise grading into tolerance. With egg and milk both do this, that when you have highly cooked foods, the proteins denature and are less recognizable to the immune system, so that children can tolerate food that's been baked, like a malted milk biscuit, but less well-cooked forms will still trigger an allergic reaction. And these ones who can't even tolerate baked are the ones who often have quite low reaction thresholds as well. Difficult to avoid. And so it's therefore important to always consider anaphylaxis as someone with a known food allergy who has sudden breathing difficulties, particularly in children with asthma. Nick Sargent, who's one of the consultants in Bristol and Bath, did some work with me a few years ago now, looking at admissions to the intensive PICU with anaphylaxis. And in the case series that we reviewed, about 1 in 20 also met criteria for food anaphylaxis. But had been labelled as having asthma when they were on the unit. So food allergies and asthma is a big risk factor. It's known that children with poorly controlled asthma are at higher risk of breathing difficulties if they have a serious allergic reaction. And for people with both asthma and allergy, there's a higher risk for more severe allergic reactions. So to improve, one of the outcomes they said was improving communications for food allergy and asthma. So communicating allergy symptoms to healthcare professionals. Ask about allergies at asthma review. Do they have food allergies? Do they have airborne allergies? What's their hay fever like? Is it a trigger for them? Do they get wheezy when they're in contact with foods? And incorporate food-specific questionnaires into the asthma review, potentially put an emergency plan in place with the consultant specialist. We have standardized food allergy action plans that talk through recognition and treatment of anaphylaxis. And I think I'm going to go through that with you now. So things that you can do to help. Refer into secondary care in the event of poor asthma control in children with food allergies, so they have scrupulous asthma control. Either even if it's due to poor treatment compliance or severity. And professionals should be raising awareness for children and their parents of the risk of life-threatening anaphylaxis in children and young people with food allergy and asthma, not to scare them, but to make sure that they take asthma seriously. I think you can do it in a way that empowers families. You say the biggest thing you can do. People are worried about their food allergies, rightly so. You know, it's a pervasive thing to have. Every time you open your mouth to take a drink or eat, you have to think about what the label is. But to say empower them that if they want to take control of their food allergy and put themselves in the driving seat, looking after their asthma is probably the best thing that they can do. And then having personalized action plans should have details about how to take the medication, and we also need that for adrenaline auto-injectors as well. Let me just talk to you about that. So, whoop. So adolescents and young people at higher risk of severe fatal anaphylactic reactions to food. They are increasingly independent. They're often eating out with their friends. Many of them don't like to make a fuss and ask about food allergens when they're in a group situation. And many of them won't be carrying their adrenaline, which doesn't help either. So cofactors, we know, are factors that make an allergic reaction worse, and asthma by far and wide is the most important cofactor. Poorly controlled asthma is a major risk factor for anaphylaxis and for refractory anaphylaxis that does not respond to adrenaline. Exercise is also a risk factor, either having just exercised and then having contact with a food allergen, or having contact with a food allergen and then exercising after that. So for our food immunotherapy patients, we ask them to rest for several hours after they've dosed at home to prevent this from happening. Even something simple as during an allergic reaction, walking to gain help, walking across school to go and get your adrenaline auto-injectors, walking to a pharmacist to seek medical advice can trigger an anaphylactic reaction in something that wasn't like that. And then we know that other factors are there as well. So being acutely unwell, having a fever, lack of sleep, stress. So this is often associated with long distance travel, alcohol and in some, and then non-steroidals in some as well, but not for everybody. These are all cofactors, and often with a anaphylactic death, you'll find that several of these cofactors are present all at the same time. They come together. There's a constellation of cofactors that just mean it's just happened just at the wrong time for this patient. So in terms of treatment of anaphylaxis, we all know about the adrenaline auto-injectors. We have two brands on the market. We have EpiPen in 2 doses, 0.15 milligram for children 30 kilos and below, and 0.3 milligrams for children 25 kilos and above. So there's that 5 kilogram window where they could be carrying either safely. And Jext are another brand of adrenaline auto-injector, and they have a similar dosing structure as well with 0.3 and 0.15 milligram pens. New onto the market in the UK is a nasal spray adrenaline called Neffy in the US and HIOW in the UK. And then currently there's a 2 milligram device available, although there'll be a lower device we expect in the next year or so. These are used for treatment of anaphylaxis. This is the data on the Neffy pen. You can see here that we have, this is a phase 1 data. These are healthy adults, men and women, a variety of ethnic backgrounds. And they're given a single dose of Neffy. In this, Neffy is the green bar, EpiPen is the blue bar, and epinephrine adrenaline by just a needle and syringe intramuscular dose, 3.3 milligrams, is in the yellow bar. And so over time here, 0, 30, 60 minutes, you can see that everything that they all rapidly absorbed, EpiPen being the most rapidly absorbed. You get this initial rise and then a drop off with the epinephrine IM. And you often see this biphasic peak with adrenaline, because what happens is that there's vasoconstriction around the intramuscular dose. So the muscle vessels spasm with the adrenaline, and that blocks absorption. And then as the adrenaline dose, as that drops off, then you get reabsorption again. And you can see how Neffy compares favorably with the other devices, rapidly peaking at around 30 minutes, whereas adrenaline peaks, EpiPen peaks around, what is it here, sort of about 5 minutes. So slightly slower, but you're still getting peaks of adrenaline into the system. And then they did repeat doses as well. And they looked at Neffy, 2 squirts. I think it was 10 minutes apart. 10 minutes apart here. The dark green is Neffy given in alternate nostrils, first in the left, second in the right. The second one, the light green bar, is Neffy being given into the same nostril, both into the right nostril, and then that compares to EpiPen, first dose in the left and second dose in the right, to try and avoid injecting that second dose into an area of muscle where there's already vasoconstriction. And you can see here that on repeat dosing, you get higher peaks of adrenaline with neffy than you do with the EpiPen, but EpiPen gets to its peak earlier, and that the neffy given on alternate doses does peak slightly higher, but you get the sustained peak with delivering it to the same nostril, which is interesting, isn't it? Considering that we think it vasoconstricts, that if you give it to the same nostril, actually it's broadly equivalent, if not slightly better, in terms of absorption, a quick absorption of adrenaline. This is how you give the nasal spray. So those of you who prescribe nasal steroid for allergic rhinitis, we always talk about a cross hands technique where you use the opposite hand. Have I got a? No, I've not even got a neffy at my desk. I have got a neffy. Here's one we made earlier. So you talk about cross hands technique for nasal steroid. We don't use cross hands. We use the same hand in the same nostril. You literally hold it like this, and it comes with a firing thing here, and that clicks. You have to put a lot of pressure on it, and it clicks and delivers one spray. And you put it into your nostril to a point where your fingers touch the outside of your nostril, and then you hold and spray straight up. You're not trying to spray it against the side wall like you would do with inhaled steroid. You spray straight up, and then a second dose with a different device. This is a one shot only. If you need to give it, you put it into the same nostril because of those pharmacokinetics we've already discussed. Thanks, Steph. So this is the only data that we have for neffy. It's been approved by the FDA in the US and by the MHRA in Europeans based on that pharmacokinetic data as equivalence. We've not had a randomized trial looking at how uronephy compares in the treatment of anaphylaxis against EpiPen in field situation or in a hospital-based situation. So uronephy looks like a parachute, and we can see from the pharmacokinetics that it acts like a parachute, but we have very limited data of people who have actually jumped out of a plane with it at the moment. But it is prescribable in the UK. They've priced it in a competitive manner because it has a much longer shelf life than the adrenaline auto-injectors. And it is expensive, but the idea is that one of these, if you're keeping it, you don't use it. Most of our patients don't, fortunately, because they don't have anaphylaxis. Then the price is the same as a couple of EpiPens because it will last as long as a couple of EpiPens, and it has the advantage of not needing to be refrigerated or kept at a reasonable temperature. So treatment of acute allergic reactions, we like parachutes as analogies. They have and a parachute analogy for using an EpiPen is how you think about it for treatment of anaphylaxis. It has a double action. It acts like salbutamol, it's a beta-2 agonist. It also acts in terms of vasodilation. Although it does vasoconstriction, it actually has a positive effect on the circulation in terms of managing anaphylaxis and treating the effects of circulatory shock. But it also stops basophils and mast cells from degranulating. And so the quicker you give it, you actually turn off the allergic reaction. So many people who succumb to anaphylaxis either use their adrenaline late or not at all. So just like a parachute, if you jump out of a plane, you pull your parachute cord, you pull it early because you want a soft landing. And parachutes don't work very well if you're only 5 feet off the ground. So if they develop breathing problems or feel they're about to collapse during an acute allergic reaction, that's when you use your adrenaline. And if you're not sure, you use your adrenaline. Treatment of allergic reaction positioning is also important. You don't do it standing up. Lying down if they can. If they're acutely short of breath or if their airways compromised, they find a comfortable position, just like management of croup, and that's when you give the adrenaline that way. You don't do it standing up or sat up if you can avoid it, because you can have a thing called empty ventricle syndrome where you just don't get the flow back, so you then make your circulatory issues worse than better. So you're trying to get them in a situation where you've got some flow. You okay? We're okay for timing?
Yes, please.
I think someone's.
Yeah, it's still good. Yeah, all good.
Okay, thank you. And then they give the adrenaline and they call 999. And if there's no improvement after 5 minutes, they give a second adrenaline dose into the opposite leg if you can manage it, or the same nostril if you're using neffy. So when do you prescribe adrenaline? So this is from Liz Angier's paper translating the BSACI guidance into primary care. And you see we've got a complicated algorithm. Let's make that a little bit simpler. It's really, really straightforward. If a child's got food allergy and they've not got any asthma, most of the time they don't need to have a pen if they've had a mild or moderate reaction. If they've got asthma and they've had a mild or moderate reaction, or they've reacted to a trace exposure of food, then they need to be carrying adrenaline. And if they've had a severe food allergic reaction, regardless of that asthma status, they need to be carrying adrenaline. And you're more than welcome as a prescribing community to initiate adrenaline prescriptions for patients where you think it's needed and refer them on. So I wanted to talk a little bit about peanut immunotherapy as we had a few more minutes. Um, and so I'll just rattle through some data about this. So food allergy, for many years, the treatment has been avoid it and carry a first aid kit. We're now moving into a situation where we can desensitize people, and for some, this leads to permanent tolerance. But they still need to carry their first aid kit whilst they're during the process. So peanut oral immunotherapy, Palforzia was licensed a couple of years ago. The top dose is about 300 milligrams of peanut, which is the equivalent of about one kernel of peanut. And it comes as capsules. You don't take the capsules, but you break them open and sprinkle them into yogurt or some other kind of food, and then eat that as your dose. And you have to rest following that to stop you from having exercise-induced anaphylaxis. So this is a study, the Artemis study, that we were involved in here in Southampton, and this is the outcome in children 4 to 17 years old in after 12 months of as the updosing and then maintenance 300 milligrams Palforzia. And they had an exit food challenge, and they looked at single doses here, but actually the cumulative doses that you get. So one peanut, two peanuts, 3.5 peanuts, 1.5 peanuts, about 3 peanuts, and about 7.5 peanuts here. You can see that 58% got through a cumulative dose of 7.5 peanuts without reaction. And the reactions they did have were much less severe than the 2% that were in the placebo arm at that point. So it increases your reaction threshold and it decreases the severity of the reactions. And so following that, Palforzia was licensed, and then NICE approved it for treating young people with peanut allergy. But unfortunately, it wasn't any money associated with that NICE approval, and it was expensive, not only the cost of the medication, but the cost of the staffing to run a service where you're having 2 weekly updosings and monitoring them between times. So the uptake was very poor. So this is the kind of steps that I've been using. Um, we have an initial dose escalation with Palforzia. This is how it works. That first day is like a mini food challenge, but a tiny doses, less than 1% of a peanut, and the training's there. And then from there, you take it on a 2 weekly basis. They have these packs they take with them, and every day you open the capsules and dissolve that, and then take it on a daily basis. Each updosing visit is observed in clinic, and they take a pack every day, gradually working their way up until they're on the top. Once they're stable on maintenance, you can then switch them over to dietary peanut. And for most kids, if they're not milk allergic, would use peanut M&Ms. Seem to be quite good. Obviously, in younger children, you can't do that because it's a choke hazard. And then they stay on peanut M&Ms instead of being on expensive Palforzia, and they stay on that for as long as they want to have protection. It works a bit like a parachute as well. You've got to keep the um, boat going with the parachute on the back, and when you stop the boat, the parachute comes back down again. So you're looking at desensitization, but in younger children, that can actually lead to permanent tolerance if you want to do it for long enough. So we were looking at nationally looking to see what the uptake of immunotherapy is, and we added in peanut immunotherapy when Palforzia was licensed. There was very limited uptake actually. This is growth of registry since its start in 2018, and you can see that it's got at that point it had so this was nearly a year, about 9 months ago. It had nearly 4,000. We've now got about 4,500 consented participants for all forms of allergen immunotherapy, adults and children around the UK on the registry. These are the participating centres, and you get a feel for how across the UK ability to access allergen immunotherapy is pretty limited, really. It depends on where you are. I think that Northern Ireland, you get because they've lumped it all together here, it looks actually there's more access. But if you look at the different counties within Northern Ireland, like you would do in the UK, you'll find that it's centred around Belfast. And they're centering around London as well. If you live in Scotland, you've got very limited access to immunotherapy and long distances to travel if you want to access care. So we looked at access and inequalities to access and immunotherapy, and I just wanted to show you this headline result that this is index of multiple deprivation of the participant's home postcode for England, because that's where it's available from. And the deciles, the darker this, that means that the population is split into 10 equal deciles, brackets, with the light bars, the first decile being the most affluent, and the dark red bars being the most deprived. And you can see that this is predominantly NHS funded. There are private in here as well, but they're less than about 3% of the total. This is NHS care. And you can see that despite NHS care, which is free at the point of access, we have marked disparities in access to allergen immunotherapy. You're about 3 times more likely to get it if you're in the top decile than you are in the bottom. And you know, that's not a surprise. The NHS has been like that since its inception, that those who are able to access care do, and they do so for free. So I want to talk to you a little bit about peanut, how this is developing. Palforzia has been very expensive, and there's been some advantages to Palforzia, which I won't go into because I haven't got the time. But there's also it's also not been taken up by the NHS because it's too expensive. This is epicutaneous immunotherapy, and so instead of using an oral, we use a skin-based patch, and this patch is clever. It's got a little chamber with kind of like a foam ring around it, and then there's this titanium kind of cover to the patch, and it's sprayed on the inside with peanut protein, tiny amounts of peanut protein, 0.25 micrograms, so like a less than 1,000th of a peanut in terms of protein content. And that sits over the skin, and it makes a condensation chamber that dissolves these proteins that are then picked up by Langerhans cells in the skin and shown to the immune system, leading to desensitization. So people go, well, that's from what I understand about allergy, that really shouldn't work, because the whole thing is about dual allergen exposure. We know in infants, if you can get them to eat peanuts as one of their first foods, it tells their gut that that peanut is a food rather than a part of your environment, and they make happy immune responses to it. And you can prevent them from developing peanut allergy, even high-risk ones. Whereas if you see it through their skin, and particularly eczema skin in infancy, then that's picked up by the immune system as being not right, and it causes IgE sensitization. So how on earth does a patch stop you from desensitize you? And I think it's all about timing. Basically, the longer this patch is present, the more it mimics natural exposure to pathogens, which you have to desensitize to. So it does work really well. So there's been a range of studies. Cherry Alviani and myself were this morning at the site initiation visit for this study, Comfort 1 to 3 years of age. We hope to be open very shortly, looking at the progress of this Viaskin peanut patch to hopefully licensure. So we've been involved in Epitope and then the open label EPOPEC study following that, and Vitesse most recently. The issue that they have is not that it doesn't work, but actually trying to get it to stick on a younger child for the right period of time is tricky, but they've worked very hard at sorting it out, and we are just showing that it sticks nicely now. If we can get it to stick for long enough, then I think they will have the data that will lead it to be licensed, and I hope that will happen within the next few years. So watch this space. So that's all I had to say today, and I'm happy to take questions at the end. Thanks very much.
Thank you, Mish. That was really good. We'll save questions to the end if that's okay, and let Gary do his presentation next.
Yeah, you sure? Yeah, okay.
Yes.
All right. Okay. Okay, tense moment. Am I sharing in the right way?
You are, yeah.
I am. Excellent. Great. Thank you. So my brief for this particular meeting was to talk about focus on recurrent admissions with wheeze and what should we do with them. And I'm going to show you some recent data looking at some of the outcomes that we're achieving across Hampshire and Isle of Wight as a result of our guidance in relation to asthma admissions. So I'm going to break this talk down into two halves. Am I progressing? I am, I think. So I'm going to talk about preschool wheezers separately from school-age children who wheeze. And there are some really important differences, I think, between these two groups of patients. And I want to emphasize the differences and get some thinking around why we should be approaching children with wheeze in different age groups in different ways. So an important take-home message from today is that preschool wheezers are not the same as older children who wheeze. And I'm going to give you some examples of where that's the case. And we've just heard Misha's excellent talk about allergy. And the presence of atopy, as you know, is one of the highest risk factors for predicting asthma in childhood. But it's quite a complicated relationship. And if you look at demographic data and population changes over time, there's no real clear relationship. And it's particularly the case in preschool wheeze. We know that in the school-age children, a history of atopic conditions, eczema, rhinitis, will increase the probability of asthma in children who are wheezing in that age group. We know that atopy increases the childhood risk of asthma. And we know that the IgE markers for atopy, looking at the food allergens, which Meech was mentioning, and the air allergens, are also predictive of late childhood asthma. But the relationship is less clear at the time of symptoms in the preschool population. And if you look at phenotypes of wheezing, the intermittent wheezers versus the more persistent wheezers, there's no clear relationship between the pattern of asthma and the presence of atopy. And if you look at blood eosinophils, if you look at those blood tests even to guide therapy, it doesn't really play out that you can use those markers as a guide to the effectiveness of medical treatment. So in the preschool age group, it's less clear cut. And so the emphasis of what we've been trying to put forward in terms of managing asthma in this age group, managing wheeze in this age group, has been very much around a symptom-based approach to therapy rather than using these other factors as a means for guiding treatment. This is controversial, but it's true, and it's about the evidence base that supports the use of action plans, and we have these as very much an integral part of our practice for managing wheeze and asthma in the school-age children. We've got good evidence that having an asthma care plan is very effective in reducing frequency of exacerbations, visits to the ED department, and overall improvement in quality of life. But this all again falls down when you look at the preschool age group. And this is BTS sign meta-analyses from a few years back. And their conclusions were that there's really little evidence that self-management strategies delivered to parents of preschool children are effective. They don't work. The trials which have been done, which have randomized children in the preschool age group to having these care plans versus no care plans, show no impact on ED visits, hospital admissions, and unscheduled consultations. That's perhaps surprising and not what we might expect. But I want to try and revisit this later on and just think a little bit about why it might be. It might be related to where we're putting the emphasis in terms of management in supporting and caring for the wheeze in this age group. Medication might also be a factor here in terms of what those care plans look like, particularly if it includes drugs which have good evidence of not working. And we've been through a cycle of Montelukast being the greatest medication for asthma because it's a convenient oral given therapy, to now very good large randomized controlled trials over 3,000 children failing to show benefit of using Montelukast either intermittently or continuously for preschool wheeze. These studies are negative and don't show efficacy. And similarly, azithromycin's had its moment, the interest about the microbiome and the possible role of bacterial infection in compounding and adding to a phenotype of wheeze. The studies have been done just recently in America, a very large Tucson study led by Fernando Martinez. It's not yet published, but the data was in the North American conference last year, and essentially they stopped early because there was no signal. So antibiotics don't have a role here for wheeze in this age group either. What does work, and I think we know this, is inhaled corticosteroids. That's been around for some time with an evidence base to support that practice. Again, the devil's in the detail. There's very strong evidence that regular inhaled steroids are good for children with recurrent wheeze with persistent symptoms. So continuous steroids for children who are wheezing or having other respiratory symptoms such as dry nocturnal cough is an effective treatment approach. And children with intermittent asthma, there's evidence that continuous steroids are poorly effective, but there is strong evidence to support intermittent inhaled steroids for preventing exacerbations. That hasn't got into UK guidance. It's got A-level recommendation in all sorts of guidelines across the world. But the difficulty about the implementation of that approach is about dose. But I'll come to this again a little bit later on about what we're thinking about what we might do locally in relation to following the evidence that this approach might be effective. We know that in school-age children, dose doesn't matter when it comes to inhaled steroids. 79 randomized controlled trials comparing low dose with higher doses of inhaled corticosteroids to try to impact upon acute asthma attacks. They're all negative. The stepwise approach to treatment we've had for decades was not evidence-based, and we really need to abandon that. That's quite different from low dose to medium dose MART, which we do have in our guidance, and there's good evidence that an increased MART dose of prevention therapy can be effective, more so than low dose in those patients poorly responsive to low dose MART therapy. But for fixed dose combination steroid treatment, high versus low dose, with or without LABA as the treatment approach with SABA relief therapy, no effect on dose for school-age children. Paradoxically, in preschool wheeze, there is some evidence to suggest that dose might matter. And that's probably to do with the reasons why the intermittent inhaled steroids in high dose are effective. And it's probably also to do with the actual dose delivered. The dose response curve in this age group might be around the sorts of doses we might be incrementing. Here, studies showing fluticasone 100 to 200 micrograms a day, reducing acute wheeze episodes in the preschool population, a dose response. The doses are probably very low when we're using spacers with face mask attachments. And so we're probably still within the dose response curve in some patients if we have incomplete response. That may have some implications for how we use inhaled steroids in this age group. So these are our imminently about to be published peer guidelines for preschool wheeze in the 1 to 5 year olds. We're just awaiting some governance in relation to the sign off to put them on the peer website from Southampton, which we're hoping to have very, very soon. I just want to take you very briefly through some of those. It's a 2-page simple document, and I've tried to be as pragmatic and as clear and as simple as possible. Had lots of input and support from various people in primary and secondary care to try and get this right. And we've come up with 3 groups of patients. Group 1 being those patients who have intermittent wheeze and don't come anywhere near a hospital, just managed in primary care. Group 2, patients with intermittent wheeze and who come to hospital either more than once to ED or 1 hospital admission, or patients who have intermittent wheeze with interval symptoms. So there's something else going on despite the acute episodes, other triggers causing symptoms, or persistent nighttime cough, a dry nighttime cough between acute episodes would also put you into category 3. We need to recognize that when we look at patients, looking at young people over time, they can change from one group to the other. These are not static categories. We talk about these different phenotypes, but they are interchangeable over time in any one individual. Children who need IV treatment should really be seen in secondary care. And a big theme of mine, as many of you will know, is the importance of supportive care as being something we should consider in improving outcomes. So you go down one of 3 treatment pathways. They're very simple. If you're just having intermittent wheeze in primary care, you have salbutamol as needed. If you're in group 3 and you've got interval symptoms, you have regular inhaled corticosteroids. We debated long and hard about the dose. We came up with Clenil, 100 micrograms twice daily. And if you have intermittent wheeze, we then would introduce intermittent inhaled steroids, and the dose within the guideline is 200 micrograms twice daily. That is less than what's been in the published research, but we feel that the higher doses were not something that we could be recommending at this stage. We have a time limit on that of up to 7 days. And got some clear asthma care plans, wheeze care plans, which advise on this approach. One little small print is that this is for not for the ultrafine beclomethasone, the QVAR preparation, which is not recommended in this age group. This is using beclomethasone, Clenil, or Soprobec inhalers. Why did we choose patients with 2 ED admissions or 1 hospital admission? Well, this is some data from Southampton looking at the ED attendances over a 1-year period and looking at the likelihood of reattendance with wheeze in the subsequent year after each patient's attendance. And we had 644 children who attended between December 22 and November 23. And of those, a third came back within a year. And if you came back within a year, then you had more than a 50% chance of coming a second time again, a third time, reattending twice. So we thought that that was probably the most important point of intervention. If you come back with a recurrence of wheeze, then you've got more than a 50% chance of coming back another time. And so that's the group we should target with intermittent inhaled steroids to try to impact upon that high probability of hospital reattendance. And this is an example of our care plans. Many of you will be familiar with these for the older age group. We've got 3 of these, one for salbutamol alone in a primary care setting, number 2 with the use of intermittent beclomethasone, and a third one for continuous inhaled corticosteroids with those with intermittent symptoms. So they'll be very shortly up there on the peer website. A few little bits of information on the second page of the guideline. It's very hard to be definitive about asthma in this age group. We can't do objective tests, and many of the children who wheeze in this age group do not go on to develop asthma in later childhood. There's some controversy around this. There's been some diagnostic coding suggested around possible or probable asthma for wheeze in this age group, depending on severity and pattern. But we've resisted that locally because of the connotations and the morbidity that can be associated with a label that doesn't have an objective basis and may well be wrong, given the lack of objective data to support such diagnoses. We do recognize that amongst the children who do have allergic disease and who typically respond well to inhaled medication, they are more likely to have asthma continuing into later childhood. So there is that phenotype that we see typically in older children presenting in this age group. But an important point is it's the minority of patients who wheeze. So it doesn't necessarily guide treatment, but it does have some implications for prognosis, all being that it should be also quite responsive to asthma therapy, because it is going to go on to become asthma in later childhood. The children who have intermittent wheeze with no interval symptoms, there's good prospective data showing that those children are just as likely to get better and not have asthma in later childhood as children who don't. So intermittent wheeze has a good long-term prognosis in the majority of cases. It's a very clear message. Parents are often very distressed by those acute episodes and hospital presentation and the prognosis, but we can be very positive for the majority of patients. It's important to recognize the importance of other irritants that may be playing a part in symptoms. Smoke exposure, vape exposure now as well, and air pollution are important risk factors which have now been shown to be important comorbidities which impact upon the severity of wheeze, albeit that viral causes are what trigger the hospital presentation, but they can be made worse by these other comorbidities. And so that's important considerations. And anyone who's heard me speak before knows that I bang on about the importance of anxiety. We know that antenatal stress is the most important predictor of wheeze in the preschool age group after atopy. And there's an ongoing issue about the extent to which anxiety plays into presentations with wheeze as it continues postnatally. And there's a little bit of data here from, again, a third year project done locally, just looking at treatment in children who are repeat attenders in the preschool age group from 1 to 5 years with recurrent episodes of wheezing. And what we've done here is we've grouped the patients into 7 groups based upon the number of times they've come back over a year. So 1, 2, 3, 4, 5, 6, more than 6. And we looked at the treatment, the percentage of times they've had burst treatment or oral steroids on the basis of those presentations. And what's very clear here is that the repeat attenders are actually often the worried well. They're not having as much burst treatment and perceived to have the need for oral steroids as those presenting less frequently, suggesting that it's not perhaps that disease severity is the main driver for repeat hospital attendance with recurrent wheeze in this age group. And it's probably more about the anxiety of families who have been very worried about a child, and their illness behavior then becomes one of early ED attendance for further assistance in the event of further wheezing episodes. So this really stresses the importance and value, I think, of the supportive care aspects, reducing parental anxiety, giving them some tools to perhaps address disease severity more objectively, and to safely manage their children at home to impact upon this type of thing. A little bit on the end of the guideline about the use of regular inhaled steroids. In the same way as we do in the older children, to always wean and reduce treatment in those patients who have little or no ongoing symptoms to the lowest dose needed to control symptoms, and an expectation of recovery in later childhood, and an expectation that treatment might well be successfully stopped in, I would say, the majority of cases, which often runs contrary to what parents will see if they Google this on the internet and will be told that asthma is for life. Yes, asthma can continue into adult life. Asthma can recur in later adulthood, but often in the majority of cases it does improve, and in many cases stops in later childhood. There's a need to consider referral in those patients who don't respond to treatment, but also a recognition, as I've mentioned before, that that dose might be an issue in terms of lack of response. And whilst we've recommended a baseline low dose of beclomethasone, much of the research is used fluticasone in slightly higher doses. And so we've got some noise on the line there. And so just recognize that dose response issue as well. So that's what I was going to say about preschool. I'm going to touch very briefly on the school age wheezers. You by now all will be familiar with our Wessex guidelines. These are also available on the peer network. You know that we've moved very much towards the use of MART therapy in secondary school children and AIR, intermittent use of Symbicort in the less severe patients, and in the 6 to 11-year-olds, we've still got fixed dose inhaled steroids with SABA, but a switch to MART therapy in those who have poor control despite those measures. And the main driver behind this shift in care has been to try to reduce the use of SABA use. We know that the UK is an outlier for the higher use of SABA in particularly moderate and severe patients compared to the rest of Europe. We have worse mortality than the rest of Europe, and we know that SABA use here is data showing more than 3 SABA inhalers a year in orange compared to less than 3 across the old-fashioned BTI steps of severity of asthma, showing that asthma attacks there on the y-axis are more frequent in those using more SABA. So quite nice to see this data. This is a third-year project looking at the prescription of 3+ SABAs. It's the male data. Majority of our patients, 2 to 1, are male versus female, and you can see there that across the board there's a downward shift in the number of patients who are being prescribed 3+ SABAs in the different age groups. I think the green there is 6 to 11. The blue with the red dots is the entire population. You can see that there is a signal suggesting that that is now becoming less frequent. And we also looked at 6+ prescribing, and there's a similar trend there showing, again, this is males and females, a decrease in the number of patients. And this is looking at all GP practices in Hampshire and Isle of the Wight. So quite an encouraging signal. And that's associated, we think, with an increased use of Symbicort. Symbicort was already increasing, perhaps reflecting our secondary care practice before we launched guidelines into primary care as well, but that's continued in a very encouraging way. And some headline figures there, 87% of practices across our locality have reduced their SABA use, as measured by greater than 3 or greater than 6 inhalers, and 64% of practices have increased their doses of Symbicort. Another little bit of data there showing the increase, the reductions in SABA usage. What about outcome measures? This is Hampshire and Isle of Wight data looking at the impact of our guidelines on all admissions to hospital with a diagnosis of asthma. We know that coding can be limited, but I think you'll agree, compared with the grey background, there is a reduced number. The grey is being the patients in pre-COVID times numbers, and this is going forward since then. And there seems to be a nice reduction there across Hampshire and Isle of Wight, and there's similar data for Southampton, showing that trend, particularly more recently, appears to be a decrease in asthma admissions. Of course, there's also the coding for wheeze, and this is some Southampton data we've just got hold of, looking at the entire time period since our guideline launch in October 2024 up until December 25, compared to in blue the year previously. And it does look again as if there's a trend there towards a significant reduction in numbers of wheeze and asthma diagnoses coming to the ED department. So some nice feedback, I think, as for the effectiveness of our guidelines that we're now following. So thank you all of those of you who have been taking this on board and changing practice in going forward. I think we need to be looking at even greater use of MART treatment. I would suggest that all school-age children who've had an attendance to emergency care with wheeze despite inhaled steroids have had a failure of prevention therapy and should be switched to MART. So that's all hospital admissions and probably all ED attendances in that age group. We're also working with the hospital at home teams to triage all the children they get asked to follow up to advise on prevention treatment. And if they haven't started any prevention treatment, 6 to 11, they will start inhaled steroids. If they're on those, they'll go to MART, and if they're over 12, they'll go to MART. And then finally, we're working with that's the care plan recommendations for the hospital at home teams, which they've got on board and are starting to use. And then finally, we're working with the primary care networks groups, and I'm putting together a kind of an asthma kind of care package which they can share to work together with the primary care practices on local guidance. So I'll stop there. Thank you very much.
Thanks, Gary. Do you want to unshare your screen so you can see people?
Okay.
We've got a couple of questions in the chat already. I know we're a bit tight for time, but if we'd start with the questions in the chat, and then if anyone else has got questions, feel free to put your hands up. So the first question is kind of aimed at you, Mish. It's from Maria Erton, and she has asked about people with milk and dairy allergy and lactose presence in dry powder inhalers. Which patients would you say that's safe to prescribe for, and is it only contraindicated if the patient has severe allergy or anaphylaxis to dairy or lactose?
Thank you. People don't have anaphylaxis to lactose because it's a sugar, but it's the protein in that. And even in lactose BP, which is the pharmaceutical form, there'll still be a little bit of protein, but not very much. So if dry powder inhalers do contain milk proteins, and for most children with IgE mediated milk allergy and everybody with non-IgE, they're going to be absolutely fine. But there are some where I'll be a little bit careful about it, and that would be children who've had reactions to trace amounts of milk and those who've had anaphylaxis to milk as well. And particularly if their asthma is unstable, then I wouldn't be prescribing them those inhalers. There are other options. So Symbicort do an MDI, which is a metadose inhaler that doesn't have milk in its excipients.
Yep, perfect. Michael Hughes has said, thank you for a clear presentation, some interesting immunology. He's got the privilege of working in both adult and paediatric services in respiratory, but as a clinical scientist and not a medic, he notes that you mentioned about the drop-off in care during transitions between paediatrics and adult services. What can we be doing, particularly for those working between the two, to improve this handover between services?
Yeah, thank you. That's a good question. I think transition is a really important subject for all the paediatric specialties. And I think recognizing that transition for children who have food allergy, and recognizing that food allergy is a chronic disease, and in many ways it's a bit like epilepsy in that you're well most of the time and then you're not. You managing your day-to-day quality of life with it is an issue. So I don't think one size fits all. We don't have particularly good transition arrangement at the moment in that we don't have dedicated clinics, but I don't think you necessarily need that. You just need to know that transition is just as important for children with food allergy as it is for others.
It's probably one for you, Gary. Can wheeze on chest auscultation be a normal finding in a greater than 5-year-old for viral wheeze, or would you automatically start investigating for asthma?
Can it be a normal finding? Well, I guess the important message is that there are many reasons why children can wheeze, and they can wheeze because of airway secretions, infectious changes to the airways, as well as bronchoconstriction, and that is kind of the key feature of asthma is the smooth muscle is inappropriately constricting and causing wheeze to occur. So yeah, I mean, yes, there's a differential diagnosis for asthma, which is very much one to be aware of. I didn't touch on it in the presentation today, but if you look at the guidance, there is a nice list of other things to consider, as well as asthma in children presenting with respiratory symptoms in childhood. Go for it, Mish.
Thank you. Question for you, Gary. So instead of asking myself a question, I was really interested to see about the worried while representing with preschool wheeze. We know that anxiety is often related to severe episodes of disease or things where episodes where something's been missed by medical professionals. And I wondered if you'd looked into that with your recurrent attenders and whether they might have started with actually quite a severe episode or something where there was a misdiagnosis or something missed by an initial healthcare professional, which meant they had to represent.
Yeah, I don't know, Mish. I mean, it's we haven't really kind of burrowed down onto that to understand it in any more detail, but it is fascinating, isn't it? It's it's a very much a chicken and egg thing, whereas the anxiety of itself can actually drive severe disease of itself. And you mentioned about the stress and the severity of anaphylactic reactions, and there's no doubt the same is true of stress and the extent to which asthma attacks can occur. I'm sure that's very, very important, but equally the asthmatic families often have a very heightened perception of illness and can overreact to it. So it is a bit of a minefield and quite hard to navigate, but there's a narrative there that goes both ways, I think.
Does anybody else have any questions for Mish or Gary while they are here? Oh, no hands up. You've answered everything.
Hey.
Well done. Thank you very much for the great talks. Our next meeting is on May the 12th, same time, lunchtime again. I'll send invites out to everybody who has asked to be on the mailing list or who is already on the mailing list. Thank you, everybody, for joining. Hope it's been useful for everyone. And like I said, we'll upload the recording to our closed YouTube channel so that you can view it or share with colleagues later down the line. Thank you very much, everybody.
Lovely. Thank you.